Assalamu alaikum. First of all, I'd like to thank chairpersons and welcome our professors and colleagues. As a continuation of our journey with the diabetes, we have two very interesting cases regarding if there is a crosstalk between diabetes and endocrinopathy. Our first case, Ahmed, is 55 years old male patient, came to your clinic complaining of easy fatigability, decreasing concentration, and gaining in weight. He was previously diagnosed to be a pre-diabetic and was on metformin and diet therapy. He had a positive family history of thyroid disorders, as his brother was diagnosed to have a toxic multinodular goiter and had thyroidectomy 5 years ago. He was worried about having a thyroid dysfunction and asked you about the possibility of that. By examination, the vital signs were normal, and the BMI, overweight, head and neck showing palpable thyroid swelling with no lymph node enlargement, chest and heart and abdomen neurological examination, extremities were free. By investigation, CBC was normal, TSH is 8 with a normal free T4 and T3. This means that the patient is subclinically hypothyroid, and we order for TBO antibody that was positive and thyroid ultrasonography showing a picture suggesting of thyroiditis. A1C is 7.2 with a 2-hour postprandial is 260 milligram and the lipid profile showing dyslipidemia. So Ahmed has a subclinical hypothyroid and he is also dyslipidemic and he is now uncontrolled diabetes. So the first question here, if there's a crosstalk between a diabetes and thyroid disease, how does diabetes affect the thyroid and what are implications of thyroid disorders in a glycemic control? Our first question, how diabetes affect the thyroid? Actually, the answer is diabetes affecting the thyroid function even in euthyroid diabetic patient and altering TSH level and impairment in the peripheral conversion of T4 into T3. Also, the nocturnal TSH peak is absent and there's impairment in the response to TRH. The insulin resistance and hyperinsulinemia considered to be a state that stimulate the proliferation of thyroid tissue and increasing the incidence of nodularity. In a hypothyroid patient with a diabetes, the efficacy of the treatment of the hypothyroid is affected by poor controlled diabetes patients. And in hyperthyroid patients, especially Graves' disease, there is increasing in the incidence of Graves' orbitopathy in a diabetic patient more than in general population. The second question, what are implications of thyroid disorder in diabetes? Actually, the answer is a two option, either thyroid dysfunction prevalent with the diabetes or thyroid dysfunction that causing diabetes. Regarding the prevalence of thyroid disorders with type 2 diabetes, the instance of the hypothyroid is more common than hyperthyroid, with a risk factor including advanced age, female sex, TBO antibody, and obesity. While in hyperthyroid patient, or instance and prevalence of the hyperthyroid and type 2 diabetes, actually the instance of toxic multinodular goiter is one of the more frequent cause of the hyperthyroidism in a diabetic patient and the risk factor advanced age and female sex. Regarding the thyroid dysfunction that causing diabetes, actually the hyperthyroidism causing increase and instance of hyperglycemia because of the following: increasing glucose absorption, increasing in insulin clearance, and increasing in apoptosis of the beta cell with increasing in hepatic insulin resistance and increase in lipolysis, while hypothyroid, a state of overt or subclinical hypothyroid, considered to be a state of insulin resistance and lead to progression to a diabetes. Should we screen of thyroid dysfunction in a diabetic patient? Actually, it's yes, because according to the ADA guidelines in type 1 diabetes, you must have a baseline TSH and TPO antibody and thyroglobulin antibody. Once diagnosed type 1 diabetes, if it's negative, you should annually screen for thyroid dysfunction. If it's positive, you should screen for every 6 months. While in type 2 diabetes, you must have a baseline TSH, especially in an adult diabetic patient more than 50 years old and a patient that having another cardiovascular risk factor like dyslipidemia. And this is algorithm illustrate the management of thyroid dysfunction in diabetic patients. We have a baseline TSH and TBO antibody. If the patient has thyroid dysfunction, overt, you should treat according to the guidelines. If the patient has subclinical, as our patient Ahmed, subclinical hypothyroid, if the TSH between 5 to 10, you must treat it with levothyroxine, especially if there is a thyroid swelling, positive TBO, other cardiovascular risk factor like dyslipidemia. If the patient is euthyroid, you should screen the patient annually, especially in type 1 diabetes. How to manage a diabetic patient with a thyroid dysfunction. Actually, all the anti-diabetic agent can be used freely in a hypothyroid and hyperthyroid with the following precaution. Take care, don't give pioglitazone in the patient that having a Graves' disease because of increasing the incidence of the Graves orbitopathy. And GLP-1 regarding the incretin therapy is not recommended in the patient that having family history of medullary thyroid cancer or Men's syndrome. Insulin, you can give freely in a hypo or a hyperthyroid diabetic patient, but you should adjust dose after controlling of the thyroid function. How does thyroid management affecting the glycemic control in a diabetic patient? In a hypothyroid, we give the patient levothyroxine, but it may interfere with the action of the insulin and anti-diabetic patient. So you should increase the dose of the insulin and anti-diabetic, especially after initiation of the levothyroxine. While in hyperthyroid patient, because of the methimazole and carbimazole, is related to the development of the autoimmune insulin syndrome, so it may cause hypoglycemia in the patient that having diabetes. So you just adjust the dose, especially after controlling of the hyperthyroidism. Don't miss other endocrinopathy that causing or prevalent with the diabetes, especially type 1 diabetes, is commonly prevalent with other autoimmune endocrinopathy like autoimmune polyglandular syndrome, type 2 and type 3. Our next case, Nadia is 42 years old, female patient, came to your clinic complaining of polyuria, polydipsia, generalized bone ache, and insomnia of 2-week duration and associated with a current attack of UTI over the last months. She was worried because of the family history of diabetes, and she gained 8 kilograms over the last 2 months associated with the facial fullness and acne and recent diagnosis of hypertension. No history of headache, vomiting, blurring of vision, and the drug history, no history of steroid, antipsychotic, antidepressant, or COC. On a physical examination, the blood pressure is slightly high, 145 over 80 millimeter mercury on antihypertensive therapy. The pulse is normal. BMI is high. Obese patient, 30 kilogram per cubic millimeter, and waist circumference is 100. The face is plethoric and cushionic with the percent of the supraclavicular and dorsoclavicular accumulation of the fat, abdomen showing a truncal obesity with triorubra more than 2 centimeters on the abdomen, with a neurological examination revealing that there is a proximal myopathy. Lab investigation showing CBC, there is increasing in TLC with a neutrophilia with no cheft, creatinine, urea, and estimated GFR were normal, potassium 3.4, which is slightly low, sodium and calcium and phosphorus normal, vitamin D insufficient with a DEXA scan showing osteopenia, thyroid and prolactin function normal, A1C is 8 and the random is 280 with a pregnancy test that was negative. The first question here, what is the cause of diabetes in that lady? How to diagnose and how to manage? We should exclude Cushing in that lady as one of the endocrinopathy that causing diabetes. And we all know the endogenous Cushing syndrome, either ACTH dependent or ACTH independent, or patient that having pseudo-Cushing. Don't miss if the patient uncontrolled diabetes or obese patient or having a depressive disorder or psychiatric disorder or a chronic illness, you should exclude the non-neoplastic hypercortisolism. So how to diagnose our case? According to this diagram, you should confirm that the patient had a Cushing by one of the following 3 tests. One of them is low dexamethasone suppression test. Actually, in that case, we need to have the standardized 2-day low dexamethasone suppression test or CRH dexamethasone suppression test to exclude between the true Cushing and the pseudo-Cushing, and or 2 positive tests of 24-hour urine-free cortisol that must be more than 3 upper limit of the normal, or 2 positive tests of late night salivary cortisol level. If it's abnormal, you will confirm that the patient had a Cushing syndrome. Then if it's ACTH dependent or ACTH dependent according by measuring the plasma ACTH level, if it's low, so it is ACTH independent, adrenal cause, or more than 15 picogram per milli, so it is either ACTH dependent Cushing disease, pituitary tumor, or it is ectopic ACTH. We can differentiate by using high dexamethasone suppression test. If there is a suppression, so this is mean that the patient had a Cushing disease, so you must localize your tumor using pituitary MRI, especially if the patient having adenoma more than 6 millimeter. If it's low than 6 millimeter, you must have invasive method like bilateral inferior petrosal sinus sample. So our patient Nadia, the lab result showing that increasing in the level of the serum cortisol AM and PM with loss of circadian serum cortisol 8 a.m. after 2-day dexamethasone suppression test, failure of suppression, this is mean confirming that she has a Cushing syndrome. Even the 24-hour urinary free cortisol is more than 3 upper limit of the normal, and the serum ACTH is high. So the serum cortisol 8 a.m. after 8 milligram overnight or the high dexamethasone suppression test showing a suppression. This is mean that the patient has a Cushing disease, and after that we have MRI pituitary that showing a microadenoma. So the treatment of our case, mainly transsphenoidal surgery by expert neurosurgery is recommended, but we need to control the hyperglycemia actually before the operation. This is the most important question, how to manage the diabetes secondary to Cushing disease. The treatment, mainly all the anti-diabetic medication can be given in patients that having a Cushing disease, metformin, sulfonylurea with the precaution of biglitazone, that not recommended in the patients that having Cushing because of increasing in the weight gain and edema, and not give cautiously also SGLT2 because of increasing susceptibility of the infection. Insulin is one of the therapies that is important as a preoperative therapy, or uncontrolled diabetes, especially basal bolus therapy. And lastly, the other endocrinopathy that causing diabetes, don't miss pheochromocytoma, primary hyperaldosteronism, and acromegaly. And our take-home message, the most common endocrinopathy with a diabetes is thyroid disorders. A screen for thyroid dysfunction should be done once in diagnosis of type 1 diabetes and after the age of 50 in type 2 diabetes. In management of hyperthyroid diabetic patient, biglitazone is not recommended, especially in Graves' disease because of increasing the risk of Graves' orthopathy. Cushing is one of the commonest endocrinopathy that causing diabetes. 2-day low dexamethasone suppression test is recommended as a screening test, especially in the patient that's suspected to have non-neoplastic hypercortisolism, especially in obese and non-diabetic patients. And thank you.